This talk, I think, really follows well after the two talks by Dr. Levy and Dr. Laura, because you've heard about the importance of guidelines and bundles in trying to implement care for septic patients in the first 1 hour, in the first 6 hours. But really what also needs to be done at the same time is not forget all the other supportive care that we give our patients. It is not that we have all the focus on taking care of these patients and forget that we have to manage their glucose. We cannot forget about restrictive transfusion practices. Similarly, we cannot forget about what sedation are we using. Are we making sure that our patients are pain-free? Are we choosing the right sedative? Are we ensuring that these patients are not comatose in the ICUs? Monitoring for delirium. These elements of supportive care have to go hand in hand with managing your severely septic patient or your patients with ARDS, and not forget about it and then think about it 3, 4, 5 days later and say, oh, we should have done this in the early phases. So to bring that together, the SCCM, or the Society of Critical Care.
Entonces, la CCIM, la Sociedad de Medicina Crítica, ha creado
Mobility and sleep, PADIS guidelines. And I'm going to try and talk about the PADIS guidelines. And just as Dr. Levy said, you have guidelines, and then you have ways to help you implement those guidelines. And the ABCDEF strategy is one such bundle that you can use to approach how to tackle the PADIS guidelines and ensure that your patients have the best care possible for them. You may then have individualized protocols to figure out how to implement the ABCDEF bundle in your ICU. So that's how guidelines lead to bundles and then local protocols to try and improve outcomes at your own ICUs. The only disclosure of importance for this talk is that we did a study called the MENS2 study, which was in the New England Journal, comparing sedation with dexmedetomidine versus propofol in septic patients. Study drug was provided by Pfizer, earlier on by Hospira. All my other salary support is through NIH grants. So we all realize that patients in the ICU need to be pain-free. They should be comfortable. We don't want them to be anxious. We want to try and prevent ventilator-patient dyssynchrony. And as a result of that, many patients in the ICU get sedation and analgesia. But it's also important to realize that while there is a good reason that your patients might need some analgesia and some sedation, sedation is associated with worse outcomes. And even early deep sedation is associated with worse outcomes. So if your patient is sick, has just come to the ICU, in septic shock, you've intubated them, you started them on pressors, etc., keeping them deeply sedated, even in those early phases, is associated with worse outcome. This is a study done by the ANZAC group. So Yahya Shahabi was the first author. And what they looked at was within the first 48 hours, how many 4-hour epochs were you deeply sedated? And they just totaled the number of 4-hour periods in a 48-hour window that you were deeply sedated, and tried to assess the association between that deep sedation and mortality after accounting for known confounders. And what they found was that if you were deeply sedated in blue, your probability of survival was lower than if you were lightly sedated. So some data to suggest that iatrogenic harm can be done by the sedative medications that we use. Now, this is an old study, and this brings us back to some of the guidelines that we had in the early phases, and they change depending on new data. So the 2002 Society of Critical Care Medicine sedation guidelines recommended lorazepam as the drug of choice for sedation for critically ill patients. Now, some of you over here may not have used lorazepam infusions for sedation in the ICU, and that's great. But some of us who've been practicing for now over 25, 30 years, lorazepam infusions were the drugs of choice based on the Society of Critical Care Medicine guidelines, because they provided sedation in a predictive, even though long-acting manner, and midazolam, because of its water solubility, was short-acting but unpredictable. So the Society of Critical Care Medicine guidelines recommended lorazepam as the drug of choice. Many of us used about 1 milligram an hour of a lorazepam infusion, which meant that in 24 hours, you got about 24 milligrams of lorazepam given to those patients. It seems an absurd amount of lorazepam to be given now, but that was common practice in the early 2000s as well. In this study, we were looking at the association of lorazepam and delirium the following day. So how much lorazepam were you on a day, and what was your mental status the following day, adjusting for your previous day's mental status and risk factors that were happening within that 24-hour period. And while age was a major risk factor for delirium the next day, lorazepam infusions, such that if you were getting about 20 milligrams of lorazepam in a 24-hour period, which is 1 milligram an hour infusion, your probability of delirium was almost 100%. By the time we published this study, folks said, well, we've started using midazolam. Most people were using about a 2 milligram midazolam infusion. And by the time you got about 50 milligrams of midazolam in a 24-hour period, the probability of delirium the next day was again about 100%. So it did not matter which class of benzodiazepines you were using, strong associations with delirium. Again, not causality, but strong associations because these are observational studies. So the guidelines in 2013 and 2018, based on all the literature that had been published in between 2000 and 2020, changed the recommendations to say non-benzodiazepines should be used as drugs of choice for sedation in the ICU if necessary. So really full paradigm shift, benzodiazepines in 2002 and then non-benzodiazepines in 2013 or 2018 guidelines. So these are the two guidelines. If y'all are not aware of them, I'm sure most of y'all have read them, but the 2018 guidelines was a massive undertaking by the Society of Critical Care Medicine to update the 2013 guidelines and to focus on pain, agitation, sedation, delirium, immobility, and sleep disruption. Now, a framework, so the bundle that can help you remember how to implement the PADIS guidelines is the A2F bundle, which follows A for assessment and management of pain, B, doing awakening and breathing trials, both of them. C is thinking about your sedative, so C is choice of sedation. D is delirium assessment and management. E is early mobility and exercise, and the word early is key over here. And F is family engagement. And the PADIS guidelines mimic what the A2F bundle shows, and I'll try and show that to you all in the next few slides, showing you how these go hand in hand, and they're not trying to be competitive. This is meant to be to help you implement the PADIS guidelines in your practice. So if you think about the PADIS guidelines, the first letter is P for pain. In the ABCDEF bundle, the first part of A is assess, prevent, and manage pain. So again, going hand in hand, the guidelines recommend understand pain and find tools to use for assessment. And here's what the guidelines show you. It's treat pain early. So again, while you're focusing on the other elements of critical illness, like your patient's septic or your hypoxic and having ARDS, do not forget that these patients also have pain. Think about that. If you have a patient who is nonverbal, there are tools available, whether it's the CPOT or the behavioral pain scale. They are available to help you assess for pain and manage that pain and try and take care of that pain early. So the 2013 guidelines recommended that. The 2018 guidelines added an element saying that do not use vital signs as the only measure for assessing for pain. So just tachycardia and hypertension should not be your markers for pain. Add some pain assessment tools, such as either a numeric rating scale if your patient can tell you their pain, or the BPS or the CPOT, to help you with pain assessment. And then added other elements to think about multimodal pain regimens to reduce opiate requirement, that lidocaine may not be the best agent for critically ill patients, and you don't have to use that as standard of care in your ICUs. Now, taking this a step further, what those guidelines also showed was when you implemented pain management and assessment in your ICUs, care improved in patients. Now, the other element is to try and think about an analgesia first approach, that you want to manage your pain. And if your pain is controlled and your patient is comfortable, you may not even need sedation. And a study that showed that that might be true is the study done by Tom Strom from Denmark. And what they did was they did a randomized control trial. In group 1, they started all patients just with morphine, no sedation, just morphine. And so you obviously have to make sure that the patient's muscle relaxant has worn out. But after that, just morphine. If the patient was delirious or uncomfortable after being just on morphine, they did think about haloperidol to use for symptomatic agitation. And then if the patient, even after using morphine and haloperidol, if the patient was still having patient ventilator dysynchrony, they allowed propofol for 6 hours, but then you had to turn it off and go back on to just the morphine or haloperidol regimen over here. The other group, which was the control, started with what is considered relatively standard. They had propofol, plus they had morphine for pain. So sedation first versus analgesia first approach. And what they found was that the group that had the analgesia-based approach first had much better outcomes with regards to time in the ICU and getting discharged from the ICU. Now, in the group that started with morphine first, 20% of the patients required rescue propofol for a few times. So a lot of people say, well, there you go, you required propofol. But if you flip it, that means 80% of the group did not require propofol. And if you start with a strategy where you start a sedative and analgesic, perhaps 80% of patients are getting a sedative when they probably did not need it. So thinking about an analgesia-based approach first, and then adding a sedative if you require it for anxiety, for significant agitation, for ventilator patients dysynchrony, you may consider that, but all patients may not need it. And this is what we do for so many other things. We don't start people on 5 blood pressure medications and then say, oh, blood pressure went to 300, let's take it down. You start one, you need a second one, you add one, depending on what the physiology is. We don't just add 2 or 3. And with sedation and analgesia, it appears that we add sedatives even without proof that we actually need the sedative for every patient. So that's the analgesia-based approach first. Think about adding that first and then adding a sedative agent if you need it. All right, so the second part in the PADIS guidelines is agitation sedation, the A part of PADIS. And in the ABCDEF parallel framework to use as the bundle, it talks about both an awakening trial and a breathing trial. So what does the PADIS guidelines say? So the PADIS guidelines say that you have to monitor for depth of sedation. So do not talk about depth of sedation in broad terms like deep sedation, light sedation, moderate sedation. Each of us may have different interpretation of what those words mean. Use objective tools such as the Richmond Agitation Sedation Scale or CESLUS or the SAS scale. Either of them can be used to try and use more objective measures of sedation assessment. And then the other recommendation is use light sedation versus keeping them deep, and then considering daily awakening trials in these patient population. Of course, if you have lightly sedated patients, then you can still do additional daily awakening trials. I think that would be even better to do it in your patients. Now, what are the data to support daily awakening trials? And this is not a new study. This was a study published by JP Kress in 2000. Many people say it takes 20 years to put something into practice all over the world. So if that is what people believe, then the time is now, because we're in 2023. It's 23 years after this pivotal study was published. And what it showed was that on a daily basis, if you think about patients and they meet a safety screen, that there's nothing dangerous going on, that they're not actively seizing, that they're not very agitated, stop their sedation, let them wake up, see how they do. If they don't need sedation, you can then turn it off. If they need sedation, you may be able to reduce the amount of sedation such that the next day, they're only on 50% of the sedative they were getting the day before. And what that showed was that you can get people off mechanical ventilation faster if you had a daily awakening trial included in your protocol. Now, in 1996, Vasily had published a study which showed that if you do daily spontaneous breathing trials, it improves outcomes. So the question was, well, if you're doing daily awakening trials and it improves outcomes, and if you do daily spontaneous breathing trials, it improves outcomes, it makes sense that you wake your patient up first and then do a spontaneous breathing trial. What is the point of doing a spontaneous breathing trial if your patient is still comatose? Because you're not going to be able to extubate them if they pass the spontaneous breathing trial. So that was the basis of the ABC study that Tim Gerard published from our group. And the goal in the study was, in the intervention arm, you had a spontaneous awakening trial first, and it was linked to a spontaneous breathing trial. Taking together both those two studies, which had showed individually improved time of mechanical ventilation. And what the ABC study showed was that you had additive days that you were alive and free of mechanical ventilation when you combined an approach of an awakening trial and a breathing trial. So the B part in the A2F bundle is both an awakening trial linked to a breathing trial associated with improved outcomes, including a mortality benefit. So a 32% reduction in mortality. If you have a linked approach of an awakening trial and breathing trial, the amount of sedative exposure in this study was much lower than in the intervention group as compared to the control group. So if you believe Yahya Shahabi's study, which showed early deep sedation, so sedation is associated with greater mortality, other data to suggest that if you reduce sedative exposure, you might have some benefit with mortality as well. Again, these are two different studies. It's difficult to produce causality, but at least data to suggest that sedatives may be associated with worse outcomes, and reducing sedative exposure through a linked approach of trying to get people off the ventilator faster might show improved outcomes, including mortality. All right, so you may have patients that you go with an analgesia-based approach first, and that helps them. You might have patients that you are trying to do daily awakening trials, but there is a patient population that you might require sedatives for a short period of time. And in that case, what are the agents that we have in our armamentarium? So in the A part of the PADIS guidelines, there's an addressing the agitation part, which links to the C in the ABCDEF framework, which is the choice of sedatives. I showed you all some data that benzodiazepines were associated with worse outcomes. The guidelines in 2018 said that we suggest sedation strategies use either propofol or dexmedetomidine over sedation with benzodiazepines to improve clinical outcomes in mechanically ventilated patients. So a relative paradigm shift from 2002 to 2018, suggesting we should avoid benzodiazepines in our patients if we have to use a sedative in the first place. And here are some of the studies that are there to support this argument. This was done by Shannon Carson from UNC Chapel Hill. And what they did was took MICU patients who either got lorazepam intermittent doses with some targeted sedation and a daily awakening trial. So there was best practices being involved. And the intervention group just got propofol infusion, so no benzodiazepines. And what they showed was that, again, they had improved outcomes when we were using propofol over benzodiazepines. So if you looked at ventilator days were much higher in the lorazepam group versus the propofol group, and then even in the survivors. And then ICU length of stay, if you looked at that, in survivors, in the lorazepam group, longer ICU lengths of stay, shorter in the group that was on propofol. So data suggesting propofol was superior to benzodiazepines with regards to outcomes. Dr. Levy talked about studies which have showed that are there studies which have shown deleterious effects with bundles, and there are none. There are no studies that have shown thus far that benzodiazepines are superior to other agents. Other agents have been shown to be superior to benzodiazepines. In some studies, other agents, dexmedetomidine or propofol, have been shown to be equivalent, but there is not a single study in the literature that has shown that benzodiazepines are superior to propofol or dexmedetomidine. So really hardly any rationale, or sorry, no rationale to support the use of benzodiazepines, because there is no data to suggest that they are superior to anything other available in the market. This was the first study looking at dexmedetomidine. And so this is the study that I told you I had a disclosure because I got study drug from Hospira at this time. We studied lorazepam versus dexmedetomidine. This study followed my paper, which showed lorazepam was associated with delirium. So we're thinking of what alternative paradigms can we use. And what we found was that duration, or the proportion of patients with delirium, was same in the dexmedetomidine or lorazepam group at time of enrollment. But then you can see that the group that was on lorazepam had a higher proportion of delirium versus the group that was on dexmedetomidine. Now, one cannot tell whether this is because dexmedetomidine reduces delirium, or at least it avoids you being on lorazepam, which is a higher risk factor for delirium. So at least it gives you an alternative sedation paradigm to put for your patients to try and reduce the probability of them getting delirious. Now, we know dexmedetomidine is superior to benzodiazepines. We know propofol is superior to benzodiazepines. Among the two agents, are there any differences in outcomes? So this is one of the first studies looking at dexmedetomidine and propofol in septic patients. There was a study done earlier on called the PRODEX study, which compared propofol and dexmedetomidine in all comers, showing no difference in outcomes. And when we looked at propofol and dexmedetomidine in the MENS2 study, we again found no difference in outcomes. So really, at the present time, if you look at these two agents, propofol versus dexmedetomidine, the days alive and free of delirium and coma, same. Ventilator-free days, the same. And then when we looked at long-term cognitive impairment, scores were exactly the same. So at the present moment, at least data suggests that, again, you can use propofol or dexmedetomidine if you require sedation. Then decide which one is better for your patient. Overall long-term outcomes and ICU-related outcomes are equivalent if you take it across the board. And going back, there may be patients. Now, your guidelines suggest these two agents are equivalent. Then look at your individualized patients and see among those two drugs, which one might suit your patient better. And that's where you can personalize some elements of care, staying within the broad range of the guidelines recommendations. All right, D is in the PADIS guidelines, PAD, and then you come to, in the ABCDEF framework, the D, again, suggesting the same thing. So you can see that there is a parallel between the A to F bundle and the PADIS guidelines, just giving you a way to try and remember how to incorporate the PADIS guidelines into your management. The first piece is to assess for delirium. There are validated tools. The CAM-ICU is one of these tools that was validated by our group to assess for delirium. And if you think you can just look at your patient and assess them for delirium, about 70% of delirium gets missed. So using a validated tool is important. We all recognize the hyperactive patient who's trying to jump out of their bed, pull their endotracheal tube, or try and hit you. What we miss is the hypoactive patient, and majority of our sick patients are hypoactive. So that's where the tools come in to help you determine if the patient is delirious. The ICDSE is another tool developed in Canada by Joanna Skrobik's group, and that can be used over a shift to try and see whether patients have certain features. So while the CAM-ICU is a just-in-time assessment for delirium, the ICDSE gives you a temporal part where it's over a shift to assess patients for delirium. It doesn't matter which tool you use, whichever one works for your ICU, that's fine. The guidelines recommend use at least one of them. And so use one of them, and you're at least ahead of a lot of other people who are not using any delirium monitoring in their ICU. Unfortunately, there are no magical drugs yet for treatment or prevention of delirium. The REDUCE trial was one of the largest studies done for prevention treatment, low doses. So 1 milligram and 2 milligram of haloperidol for trying to prevent delirium, done in the Netherlands, really showed no difference in outcomes, whether it was delirium outcomes or mortality outcomes. And here, it comes back to the principle that delirium is a multifactorial syndrome. just like all your other organ dysfunctions, we haven't found a magical drug for renal failure. We haven't found a magical drug for ARDS, for respiratory failure, and we don't have a magical drug for brain organ dysfunction, because these are all multifactorial syndromes. And until we get to phenotyping and able to try and see what the differences are, at the present moment, supportive management is what really works for all these patients. So the REDUCE trial was a prevention trial. The MIND USA trial was a treatment trial where we tried to use haloperidol, ziprasidone as an atypical agent, and placebo to try and see whether treatment with any of those agents would improve outcomes in all comers of delirium. Again, no difference in outcomes. So you can see, I mean, there's nothing that you can show as a difference with regards to delirium days in these patients. And so no magical drug, but supportive care for patients with delirium is what is important. E is early mobility. The best study we have with regards to actually doing an intervention and having mobility very early is the study by Dr. Schweikart from JP Kress's group, showing that if you have an early mobility protocol that got people mobilized, and when we say mobilized, it doesn't mean that they have to be walking by day 2. It means that we are actively trying to see whether they can push their boundaries a little bit. If they're awake and they can move their extremities, do that. Can they sit on the side of the bed? Can they pivot in bed? Can they stand? That's all the steps that have to go before you actually make them walk. So those are kinds of therapies that were put together. And what they showed was that time in the ICU, where they were functionally independent at discharge, was much higher in the group that was the intervention group. Duration of delirium was reduced, whether it was in the ICU or whether it was in the hospital. So significantly improved outcomes if you mobilize these patients. Now, we talked about this yesterday. The ANZAC group did the TEAM study, which was the large randomized controlled trial of mobilization. It had no benefits in a large implementation study, but it was not early, and it did not have a significant difference in the intervention between the intervention group and the control group. So that might be areas to further work to try and improve outcomes with mobilization. This was a study, again, come from JP Kress's group by Dr. Bhakti Patel, showing that if you have early mobilization, you might have some benefit on long-term outcomes as well. All right, we're coming to the F parts of the A to F bundles. The PADIS guidelines did not have F as an element, or the family visitation as a strong element. This is a study coming out of Brazil looking at effect of flexible visitation. And they really tried hard to get visitation increased in patients who were in the ICU. There was no difference in outcomes with regards to delirium, etc. But surprisingly, the biggest benefits of family visitations were seen in the family members themselves. So at some time, you have to do the best for your patients. Sometimes you may want to even focus on interventions which improve things in the family. So it reduced anxiety, depression among caregivers. And really, it's important for stakeholders. If you talk to stakeholders, they say, our family matters as well. And so it may be something to try and at least include. And this was seen in COVID, right, where family visitation stopped. A lot of family members had very significant PTSD and anxiety because they were not there at the end of their loved ones' lives. We would try doing virtual comfort care discussions, but it was really such a sad state of affairs when family members were not able to come. Other studies in non-ICU patients have shown improvement in cognition with family visitation. Now, take this all together. If you take the A to F bundle, and this graph is very similar to the graph of compliance that Dr. Levy showed with sepsis. If you take the A to F bundle, and this was in 15,000 patients as a big collaborative, compliance with the A to F bundle is associated with significantly improved outcomes. So if you look at the bottom, this is 100% compliance versus 0%. Your discharge was higher, hospital discharge was higher, and death was lower. And it's really goes up based on compliance. So if your compliance is low, your outcomes are not much better. If your compliance goes higher, outcomes better with regards to discharge, ICU, hospital, and then reduced death. And similarly, your time on mechanical ventilation, the greater the compliance with the bundle, lower time on mechanical ventilation, lower coma, and lower delirium. So I'm going to conclude, since it's already beeping over here. Think of the A2F bundle as a framework to implement the PADIS guidelines. Guidelines are important, and you should have your local protocols to try and help you implement these, because they improve patient outcomes if you are more compliant. There are individualized pieces among those guidelines that you all can then put into practice, but use the guidelines as your basic framework for outcome benefits in your patients. Thank you.